Good afternoon, everyone. I'm very pleased to introduce our next speaker, Dr. Zeno Marcel, who is physician, teacher, and hospital administrator, and advising the mayor of the city of Montemorelos on the Cinco Pasos program that is well known from Mexico. And I think if I read your biography, one of the most interesting things about what you do is not only do you advise Cinco Pasos, but you work through a faith-based community. And we also have to realize that faith-based communities are communities we can work through as well. So.
Okay, thank you. Thank you very much. Good afternoon. I hope I can speak fast enough and clearly enough and keep you a little bit on your toes so that you can remain awake, okay? Well, you know, interventions can vary and communities vary, and sometimes it makes it really difficult to put something together that will have sustainability. And I would like to share with you our experience in Montemorelos. We actually ventured into this activity at a time that it seemed that it shouldn't happen. This is what was going on. We had a crisis in Mexico and really a crisis around the world regarding the H1N1 epidemic. This was not a good time to be starting issues in chronic diseases, since everybody was being sensitized about acute illnesses and acute infectious diseases. We also had, we live in a community that is a predominantly Roman Catholic town. The university where I work is a Seventh-day Adventist university, a Protestant community, community-focused university. The community itself is highly partisan. The hospital where I work is a community hospital, but it's a private hospital with extensive charity care. We had a young, progressive mayor who was coming into office, and we had a supportive state secretary of health, an ambitious federal health program, and a national and worldwide flu crisis and pandemic that was dealing with acute diseases, not chronic diseases. So this is how we started. And this is what we had. We had done some research prior looking at our community, and we engage in what is called the double whip, because not only do we have a problem with obesity in our community, as you can see from a survey of 18 schools, 1,400 students, the overweight and obesity population was 36%, the prevalence. And the malnutrition rate for these individuals was actually 19.11%. So we had an issue. The younger folks, less than 5 years of age, they were malnourished, okay? Over 5 years of age, 5 to 12, from this cohort, we had a high prevalence of overweight and obesity. Our objective, therefore, was not just simply trying to do something about obesity, but actually looking at the whole culture, the health culture of our community. And the model that we use is a psycho-socio spiritual model, because we realize that individuals, especially in Mexico, have a very strong faith-based approach to living. What we intend to do, along with the community, was, of course, to increase health-promoting attitudes and behaviors and decrease the health-destroying attitudes and behaviors. Now, what would give us credibility in a situation like that? Well, we go back to what was involved in our particular faith-based approach, starting in the 1860s. With the Battle Creek experience and the community in Battle Creek, and then later on a Battle Creek hospital that became world famous. Also, Seventh-day Adventists have been known for healthy living for quite a long time, and this article in National Geographic and the book later on, Blue Zones, highlighted the longevity and lifestyle approaches that Seventh-day Adventists have. Now, what you would see on this slide, just over on the left below, I put that picture up there, to highlight another kind of community. We've even taken this kind of approach to prisons and have found that in prisons, the lifestyle approach of helping people to make better choices even works with prisoners. They not only decrease their acute problems, but also the recidivism rate and the violence in the prisons actually decrease using this kind of approach. The Adventist approach in North America, particularly United States and Canada, there's an emphasis in the In-Step for Life. And also we had a project that was going on in Philadelphia after Philadelphia was named the fattest city in the United States. It was the Fun, Fit, and Free project, 76 tons of fun, where we worked along with the community to decrease the weight of the community by 76 tons in 1 year. Well, here's what we had. We had a visionary university, we had a progressive mayor, and we had a hospital, along with support from the state government and a federal program. This allowed us to work with the community itself and with the key players in the community to develop a community health advisory group. And this was a key player in the development of this project. The hospital took care of the back end of people who were detected and who needed certain kinds of medical intervention. The university took care of much of the fact-finding and the research, some of which I'll present in a few moments. And at the legislative level and the mayor's office, they took care of the legislative things that needed to be done. But of course, we need to have lots of involvement by regular people. Now, the leaders in any community don't necessarily carry a title. The leaders in a community are the leaders in the community because of how they are and who they are and what they do. So what we worked with was the development of a coalition of these and a convergence of vision. With that, we were able to have a shared vision among many players in the community. We had a collaborative approach, and we still maintain that collaboration. And what we did in finding solutions to real health problems in our community, we then overlaid this Adelante con 5 Pasos, or New Start in 5 steps. We overlaid it on what was already going on in the community. In other words, we weren't trying to make what has already been there and what is already being used disappear. No, we try to incorporate as much as possible and have this cross-collaboration, cross-fertilization, so that this became part of the Adelante con 5 Pasos. Okay? Now, ultimately, we have to engage the community, and if we look at it purely from the point of view of engagement, it may sound as if we are a part and we have to get them involved. The contrary is actually what needs to happen. We need to be part of the community. The community is us, okay? And we need to be everyone where the community is, which means in the streets, whether it's walking in the streets or hiding in the streets. If it's traveling in the streets and in traffic jams, well, then we have media that can reach people, whether it's in a sports event or whether at work, whether it's watching television, whether it's in the school, or whether it's in a place of worship. We had approaches to reach the individuals where they were, all with the impact of all with the intention of impacting on the family and the home. So, in order to maintain this, we adopted and morphed into the we are the community is us. We're not apart from the community, we are part of the community. We're working towards release and empowerment of the societal units, which would include the individual, the family, the workspace, the school, etc. Right? We developed strategic alliances throughout the community and within the community. Network governance was taken care of at the municipal level with the leadership of the elected officials, and we had a nonpartisan political posture that diffused some of the negative energy that was going on in the community. 64,000 people. This is a small group, but we recognize that we need to tackle things at even a smaller level. So we worked in public areas, and this just shows a little chart of the growth that we had over the 3 years since this was instituted, reaching about 8,000 people through public venues. Work areas, we had a little over 2,500 people involved in different work sites. We worked with private organizations, with companies, even with the police and the fire departments and the workers themselves in other healthcare institutions, public healthcare institutions, and the bureaucrats at the government level as well. We work with families, with communities, with schools, with kindergartens. Wherever people are, there you would find us. Now, this approach is kind of a shotgun approach. And what we realize is that doing it that way, we probably wouldn't be able to see all of the impact that we could have over a short space of time. So therefore, we worked on looking at things from another point of view that I'll describe in a few minutes. What we found so far was a growth in all the sectors. We have an estimated reach of about a little bit more than a fifth of the population, 20,000 people. We've had requests for participation. That is, at the grassroots level, people in the town would say, when will our community become involved? And by just asking that question, we realized that they are already involved, okay? Because they now want to do something about what's going on. We had, through legislation and recapturing of green spaces, 5 additional recreational areas were recaptured. And we had something I call the Husband Satisfaction Index. See, at the beginning, husbands did not want their wives to participate in this frivolous thing, this going out there and doing some exercise or whatever. They didn't really like that. Until the first group of individuals actually, let's put it this way, they became more attractive and they became more compliant, okay? And the result was that the husbands then started to encourage the wives to participate in this activity. So the Husband Satisfaction Index, I don't think it's been described anywhere else in the literature, but that's an important part of our program. We had some surprises from what we found. We were looking at helping people to change their habits in the food choices that they were making until we discovered that a large proportion of our school children didn't even eat broccoli. They didn't know what a broccoli was because they've never seen it. In their homes, in some neighborhoods, they never cook broccoli. Even though broccoli is available, they never eat broccoli, okay? For them, some of the vegetables that they know, a little bit of tomato with some cilantro put on top of a taco. That was vegetables. So we had to move to different levels of our understanding of what was going on in our own community, which was a surprise to us. It just shows that even though you're part of a community, you may not really know what's going on until you study it. This is now election time in Mexico and in our community. What we can say is that the landscape has become very interesting because health is now on the agenda, okay? Now, we have decided that what we would do starting this year was to look at the community in a different way. We decided to sub-stratify and look at the smaller pockets of population to be able to see if the profile of the individuals there and the habits and the customs and how they shop and where they shop, if these things had an impact. And we're in the data collection phase. We have about 600 people that we have already interviewed, and we have mapped, using GIS mapping, we have mapped where they come from. So this is just a little sample of where people are. And then what we'll be doing later is looking at the clustering of these individuals and looking at their demographic and other profiles. So far, what we have found is that 94% of our population still eat at home. The majority of their meals they eat at home, 94%. In other words, the issue of having food in the fast food places, that was not an issue. It's not a major issue in Montemorelos. Rapidly, you can see this was a daytime study. We looked at people in public thoroughfares, 43% were male. The average age of the interviewee was 28. 91% had some religious affiliation or some faith-based approach to living. 86% had regular 7 to 8 hours sleep at night, and 84% didn't smoke. Okay. Okay. 6.6% demonstrated some interest already in health and in preventive health. 85% expressed interest. 70% of our population, however, is sedentary. 15% don't eat vegetables at all, 19% don't eat fruits, 10% regularly eat vegetables, and 5% eat 5 fruits per day. 57%, however, believe that eating vegetables is beneficial, and 50% believe that eating fruits is beneficial. Okay. The obstacles that we have include the following, and I won't read the whole list, but local officials and the idea of programs. Typically, in many communities, things go according to the administration. If the administration is there for 3 years, and then the program lasts 3 years, and when that's finished, another program comes to replace it. So this is an issue that we have to deal with, this continuity, meeting the resource needs, because there's a lot of requests, and we don't have as much resources available to deal with that. And of course, the doctor-centered sick care paradigm that prevails not only in our community, but in other parts of the country and in other parts of the world as well. So to overcome these, we're looking at engagement, improved engagement with the local bureaucrats, and asking some of the government officials to actually remove some of the people who might be obstacles, because there are some people, because of their inability to enter into this kind of participative paradigm, they are unfit for participating in this. And I know that's a bold statement, but it's something that we've had to come to realize. We're optimistic, however, because we see strategic alliances with a win-win focus. Everybody needs to have a part of the winning. Health is now recognized as a public, political, economic issue, becoming an integral part of the community dialogue. Health is now on the table, significant and growing participation in the project by different sectors of the community. Solid agreements that have already been developed, including this one with EPOD, and university students go out into the community all the time. We have research that is being conducted to facilitate our being able to tweak the program to make it better, and of course, innovation in ways of being able to look at the community, and sustained involvement in the key community stakeholders. We have a list there of local churches, media, businesses, schools, and government. With that, I'll end. Thank you very much.